Welcome to Technically Sleeping. This is an online resource for veterinary technicians and other members of the animal care team to learn about different aspects of veterinary anesthesia and analgesia, providing up-to-date learning resources from boarded veterinary anesthesiologists and veterinary technician specialists to knock out some of the basic and advanced anesthesia topics within veterinary medicine. This platform was started by two boarded veterinary anesthesiologists, Katie Bennett and Kimberly Hassan. For more information, additional resources, personalized continuing education opportunities, and other questions, suggestions, or comments, please send all communication through technicallysleeping.anesthesia@gmail.com. This monitoring lecture will cover End-Tidal CO2. My name is Katie Bennett. I'm a boarded veterinary anesthesiologist. End-Tidal CO2, or the expired partial pressure of carbon dioxide, is measured in two different ways, either mainstream or sidestream capnography. The capnogram is the end-tidal CO2 waveform, while the capnograph records this waveform, the expired partial pressure of carbon dioxide, and how it changes during the respiratory cycle over time. Capnography is the act of monitoring end-tidal CO2. End-tidal CO2 indirectly measures and can represent cardiac output, respiratory efficiency, pulmonary circulation, and overall perfusion. This value is one of the most reliable, non-invasive indicators of cardiac function and is one of the first values to change during cardiopulmonary arrest. It is also one of the most reliable ways to determine if a patient is endotracheally intubated and not esophageally intubated. End-tidal CO2, or the expired partial pressure of carbon dioxide, normally ranges between 35 and 45 millimeters of mercury. Carbon dioxide is a byproduct of metabolism. All cells in the body produce carbon dioxide as they go through different stages of metabolism. This molecule is only removed via the lungs. Thus, the body relies on the heart to pump blood, which carries CO2 to the lungs to be expired. No heartbeat results in no reading on your end-tidal CO2 monitor. The images on the left-hand side of your screen show a patient either being ventilated or spontaneously breathing oxygen into the alveoli, or the gas exchange unit of the lung, and exhaling CO2. This short video clip, which is borrowed from a fellow YouTuber, Study Force, shows how oxygen and carbon dioxide travel throughout the bloodstream, alveoli, and the body.
Fresh air entering the lungs carries oxygen to the alveoli. The amount of gas in air or of gas dissolved in a fluid can be expressed as partial pressure, which is measured in millimeters of mercury. The partial pressure of oxygen in the air within the alveoli is 104 millimeters of mercury. Carbon dioxide that enters the alveoli from the blood causes the carbon dioxide concentration in the air of the alveoli to be 40 millimeters of mercury. Carbon dioxide is continually removed from the alveoli as air is expired. Blood coming from the heart at the arterial ends of the pulmonary capillaries has a partial pressure of oxygen, or PO2, of 40 and a pCO2 of 45. Therefore, oxygen diffuses from the air in the alveoli into the blood, and carbon dioxide diffuses from the blood into the alveoli because of these differences in partial pressures. Oxygen and carbon dioxide diffuse until there is no difference in partial pressure in the air and the blood. At this point, there is no more net movement of O2 or CO2. Therefore, at the venous ends of the pulmonary capillaries, the PO2 in the blood and alveoli is 104, and the pCO2 in the blood and alveoli is 40. some oxygen was removed from the blood to nourish lung tissue. Therefore, the PO2 in arterial blood leaving the heart is 95. Oxygen diffuses out of the arterial ends of tissue capillaries into the tissue fluid, then into the cells, and carbon dioxide diffuses out of the cells into the tissue fluid, then into the blood because of differences in partial pressures. At the venous ends of tissue capillaries, the PO2 in the blood is equal to the PO2 in the tissue fluid, and the PCO2 in the blood is equal to the PCO2 in the tissue fluid, resulting in no more net movement of O2 or CO2. The blood now carries the O2 and CO2 to the lungs. In the body, all of these exchanges occur simultaneously.
The two different ways to monitor end-tidal CO2 are known as mainstream and sidestream capnography. Sidestream, or diverting capnography, uses a pump to aspirate gas from the sampling site at the level of the breathing circuit through a sampling tube to the sensor, which is located in the main monitoring unit. This type of monitor results in better waveforms. It creates less dead space within the breathing system, less cross-contamination between patients, and the machine has automatic calibration and zeroing features. This type of capnography can have some negative aspects as well. Water from the humidity of the breathing circuit can get trapped in the line. The waveforms displayed on the monitor can be delayed due to the time that it takes to sample the gas and bring it to the unit for assessment. This type of monitoring requires scavenging or for the gas to be returned to the breathing circuit itself. The removal of gas from the patient breathing circuit is important to consider during low-flow anesthetic techniques. You're more likely to have fresh gas dilution and prone to sampling system leaks in this type of monitoring. An example can be seen here on this horse, which is intubated through a tracheostomy site. The sidestream capnometer is attached at the Y piece of the breathing circuit, which is directly attached to the endotracheal tube, thus receiving the most reliable sampling for carbon dioxide measurement. Mainstream capnography, also known as non-diverting, measures the gas using a sensor located directly in the gas stream. This type of sensor can only monitor oxygen and CO2, while sidestream monitors can measure many different types of gases, including inhalant anesthetics. Mainstream capnography has a fast response time, doesn't remove any gas from the system, thus no scavenging is required. These types of monitors can increase the weight and dead space on the circuit and endotracheal tube. They're expensive to replace as they're easily damaged, and they can cause burns. In this photo, you'll see a mainstream capnometer located at the end of the endotracheal tube in the lion. This particular model shows both a waveform and a value on the end-tidal CO2 reading. Capnography works via infrared technology. This is based on the principle that gases with two or more dissimilar atoms in the molecule, like nitrous oxide or carbon dioxide, and other halogenated agents such as isoflurane, have specific and unique infrared absorption spectra. Thus, the amount of infrared light absorbed when passed through this sample of gas is directly proportional to the concentration of the absorbing molecules. You can compare the concentration of infrared light that is absorbed in the sample gas to one of a known quantity. Thus, you're able to accurately determine the amount of carbon dioxide within the sampled gas. Complications can arise with any monitoring system, and this one is no exception. One of the major complications with monitoring end-tidal CO2 is a phenomenon called collision broadening. This happens typically with older monitors, as newer monitors have already been adjusted to correct for this phenomenon. Infrared measurement of carbon dioxide is widened due to the molecular energy uptake caused by nitrous oxide in the breathing circuit. patients that are administered nitrous oxide can have an increase in the reading of their End-Tidal CO2 if an older monitor or one that doesn't correct for collision broadening is utilized to measure End-Tidal CO2. Since nitrous oxide and CO2 have similar infrared spectra, they will overread this End-Tidal reading. A similar phenomenon happens with methane gas in ruminants, such as cows. Other complications that can occur when monitoring End-Tidal CO2 include airway burns, the weight on the endotracheal tube, which can lead to accidental extubation of your patient, an increase in breathing circuit dead space, and considerations required for low flow anesthesia. The capnogram has several parts. Phase 1 represents the respiratory baseline and should be 0 millimeters of mercury. This also represents anatomic dead space. So at the onset of expiration, only dead space gas from the airways that don't participate in gas exchange, such as the trachea and bronchioles. Phase 2 combines both anatomic and alveolar dead space, as well as some degree of alveolar gas. This beginning of expiration has an increase in that end-tidal concentration as more alveolar gas is expired. Phase 3 is the alveolar plateau containing only alveolar gas. At the end of phase 3 is where end-tidal CO2 is measured. At the end of phase 3 starts phase 0, where the inspiratory downstroke occurs. This is returning your capnograph waveform back to baseline, which should again be 0 millimeters of mercury. The two angles in the waveform are the alpha and beta angles. The alpha angle indirectly reflects ventilation and perfusion. If the alpha angle increases, this can indicate VQ mismatch. The beta angle is used to assess rebreathing. A patient that is rebreathing carbon dioxide will have an increased beta angle. When we troubleshoot different values within our monitoring of end-tidal CO2, we can describe them either as patient-related problems or equipment-related problems. Remember, normal end-tidal CO2 ranges between 35 and 45 millimeters of mercury. A high end-tidal CO2, or hypercapnia, can occur for a multitude of reasons. When we relate this to the patient, hypoventilation, or just a decrease in the amount of times a patient expires during any breathing cycle, can increase your reading in end-tidal CO2. Anything that increases your metabolic rate, such as hyperthermia, will also increase your end-tidal CO2 reading. Malignant hyperthermia is one of the more common reasons that end-tidal CO2 suddenly increases while a patient is under inhalant anesthesia. Administration of bicarbonate will be converted to carbon dioxide within the body and thus increase your end-tidal CO2 reading. Insufflation of body cavities with carbon dioxide for laparoscopic procedures can also increase your end-tidal carbon dioxide reading. An increase in inspired concentration of carbon dioxide will also increase this reading. In terms of equipment, if your fresh gas flow is too low on your non-rebreathing circuit, hypercapnia can occur. An increase in endotracheal tube dead space or exhausted CO2 absorbent can also cause hypercapnia. Like we just discussed, collision broadening is another reason that your end-tidal CO2 reading can be too high. When we look at low end-tidal CO2 readings, so hypocapnia, patient-related factors must be considered, including cardiac arrest. Assessing that your patient is alive is one of the first things to troubleshoot when you have a low end-tidal CO2 reading. Hyperventilation can also decrease your end-tidal CO2 reading. Hyperventilation can occur for a multitude of reasons, whether it's an increase in the drive to breathe due to hypercapnia, hypoxia, pain, or light anesthetic death. A pulmonary thromboembolism is where a clot forms and lodges itself within the vessels that bring blood to the alveoli to give off CO2 and take on oxygen. If a large enough pulmonary thromboembolus occurs, your end-tidal CO2 reading will significantly decrease, while your peripheral CO2 partial pressure will increase. Again, hypothermia or a decrease in metabolic rate can decrease your end-tidal CO2 concentration. In terms of equipment, an increase in positive end expiratory pressure during positive pressure ventilation can decrease your end-tidal CO2 reading. A leak in the anesthetic circuit inappropriate ventilator settings, or fresh gas flow that's too high in a non-rebreathing circuit can also cause hypocapnia. Next, we'll talk about some commonly encountered waveforms. On each of the next slides, you'll see an example of the waveform that we're discussing on the upper left-hand part of the screen. A normal capnograph waveform is located at the bottom part of the left-hand side of your screen for reference. A description of the waveform, different causes, and ways to troubleshoot or treat is located on the right side. The first waveform we'll discuss is entitled cardiac oscillations. So this is the movement of the heart against the lungs, causing small notches within the capnograph waveform. This can sometimes be removed by adding PEEP to your breathing circuit, but otherwise is not necessary to treat, as this is a normal physiologic phenomenon. This image, which is borrowed from howequipmentworks.com, shows that during the cardiac cycle, the heart can beat against the lung tissue, which can cause these cardiac oscillations. Similarly, the diaphragmatic notch that can be seen here in this waveform forms when a surgeon pushes on the diaphragm or the lungs directly during a surgical procedure. When your capnograph waveform loses the alpha and beta angle and is progressively getting smaller, we do worry about cardiopulmonary arrest. So assessing if your patient is still alive is very critical during this time. A leak in the system, which typically results in a negative slope of phase 3 and no phase 0, can also be responsible for this phenomenon. A pulmonary thromboembolism or esophageal intubation are two other reasons that you can see this waveform. Here's another example. This is a similar example of a decrease in your End-Tidal CO2 value over time. This waveform is nice and square, likely being delivered by a mechanical ventilator. But the overall decrease in End-Tidal CO2 can indicate a decrease in cardiac output, a decreased metabolism, a decrease in blood pressure, overventilation, but also potentially cardiopulmonary arrest. It can also indicate a leak in the system, but typically you'll see a negative slope of phase 3 and no phase 0. Again, ensuring your patient is alive is the first step in troubleshooting any sudden decrease in End-Tidal CO2. This waveform has an End-Tidal CO2 value of 0. It is very critical that you check that your patient is alive at this point in time. If your patient is alive, the main reasons for getting a reading that looks like this include a disconnected circuit, a very large leak in the system, or a machine malfunction. Here we see mechanical ventilation interspersed with spontaneous breaths. This is the patient breathing against the ventilator. Either the patient is too light to be mechanically ventilated and requires an increase in anesthetic depth, or is being driven to breathe due to hypercapnia or hypoxia. Additionally, if a patient is painful or has an additional stimulus that is put in place while on the mechanical ventilator, you can have a spontaneous breathing interspersed with mechanical ventilation. Again, assessing the patient's depth, analgesia, as well as other potential causes for an increase in ventilation are the ways to troubleshoot this waveform. Additionally, if the patient is able to ventilate on their own, maybe they do not need to be on the mechanical ventilator at that time. This is a classic shark fin waveform. This is known as an obstructive pattern. The increased positive slope of phase 3 indicates a partial obstruction, whether that's a mucus plug within the endotracheal tube, endobronchial intubation, bronchospasm, or a kinked endotracheal tube. All of those will result in this classic shark fin pattern. Addressing the potential partial obstruction within your endotracheal tube is the first step to troubleshooting this particular waveform. That might involve also re-intubating your patient. An increase in your inspired concentration of carbon dioxide can be due to several factors: exhausted CO2 absorbent, faulty one-way valves in a circle system, an inappropriately set up non-rebreathing system, or fresh gas flow that's too low in your non-rebreathing system. Assessing your equipment usually can help troubleshoot a progressively increased inspired concentration of carbon dioxide. In conclusion, End-Tidal CO2 is a critical aspect of monitoring the anesthetized patient. Normal values range between 35 and 45 millimeters of mercury. These values can help to determine adequate cardiac output and circulatory function. They can help you assess appropriately protected airways with a no-leak anesthetic system. These values can indicate the presence of comorbidities, such as malignant hyperthermia. An appropriate end-tidal CO2 reading can ensure that the patient is still alive. It can indicate the depth and adequacy of ventilation and help to assess respiratory patterns. Different waveforms can help diagnose issues with the anesthetic equipment and/or the patient's ventilation and circulation capabilities. This allows for assessment of ventilation without having to use invasive methods, such as arterial blood gas monitoring. Any questions can be directed to technicallysleeping.anesthesia@gmail.com.